Good afternoon and a very warm welcome to NITRD CTD NTF Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to extend a heartfelt welcome to our esteemed DDG Madam Dr. Urvashi Singh, the directors and teams from NIRT and NTI, STOs, directors of STDCs, faculty members from medical colleges, district TB officers and medical officers, and all other distinguished participants, a very warm welcome. I'm Dr. Neeta Singla. I'm the Nodal Officer of DRT Epidemiology, and it is honor to introduce the faculty from NITRD. On my right is Dr. Rupak Singla. He is consultant in the Department of TB and Respiratory Diseases. On my left is Dr. Saroj Meena. She is a pulmonologist at NITRD. It is my pleasure to welcome our director, Dr. Upasna Agrawal. Dr. Upasna Agrawal has a vast experience in TB and internal medicine, and she's been a great motivator of Echo Clinics. So I request Dr. Upasna to give her introductory remark.
Good morning, ma'am. Thank you very much for the kind invitation. Good afternoon. Good afternoon to DDG, ma'am, to all the esteemed faculty and participants who have joined from different areas. I can see Dr. Bhardwaj, whom I had met recently. Hello, Dr. Bhardwaj, sir. And ma'am, can you please just let me know about the topic? I somehow have misplaced the agenda. What is the topic today?
Ma'am, we are doing a case on, we are basically managing the case of BPAL failure.
Oh, that's very, very interesting. And what this center is
This is from UP.
So,
Yeah.
So, and I really congratulate our doctors from UP who have brought such a wonderful case of BPAL failure. With the advent of BPAL, I know these questions will come, these things will come on BPAL failure. And I think it is said that we learn more from the failures than from our successes. So, welcome. Thank you for joining with all the enthusiasm. And I hand over the mic to the team.
Thank you, Dr. Now it's my privilege to welcome our DDG Madam, Professor Dr. Urvashi Singh. She is the guiding force of our NTP family, and her presence today is a source of great motivation for all of us. She has taken a keen and personal interest in all our difficult to treat TB clinics, and we always look forward to her invaluable guidance. I request ma'am to deliver her address.
Good afternoon, Dr. Neeta. Good afternoon to all esteemed seniors, Dr. Behra sir, Dr. Bhardwaj sir, Dr. Singla sir and Dr. Neeta Singla, who've been actually working on difficult to treat TB clinics, and of course, the support from Director NITRD, Dr. Upasna. Your encouragement has kept them going, and of course, their own commitment to the cause of DRTB. They have been contributing immensely with different topics they cover. Every clinic, it's a different topic. And I think the topic today is interesting because in the process, we will go over the BPAL M guidelines. Let us refer and take pride that India has not talked of the BPAL, where a lot of questions are already coming up globally. You can read in publications where BPAL is failing. We have at least ensured this is BPAL M by India. So, the idea of bringing this case we will be able to revisit the guidelines, and we will be able to revisit the inclusion exclusion if the BPAL M was initiated, taking into account the inclusion criteria, the exclusions which should have been taken care of right in the beginning. And these inclusion exclusions are very important because inclusion we have oversimplified. Earlier, we had to have resistance to fluoroquinolone or absence of resistance to help us decide shorter or longer oral regimens. But now with BPAL M, what we have clearly said is we do not need resistance. We do not need to have the knowledge of FQ resistance because we're giving this to both FQ sensitive and FQ resistant MDR TB patients. So the inclusion is simple. We are not waiting for DST. We're not waiting for LP. Of course, inclusion criteria there are a few other clinical and other drug exposure criteria as well. But the exclusion also is very, very important. We cannot give it to extrapulmonary, and of course, I'm sure Dr. Rishi, who's known for his presentations, how he makes them, he'll be thorough and he'll include all that. But I think the message today is important for all the medical officers, our DTOs, our program teams who have joined us today, that when to put a patient on BPAL-M and how to ensure adherence, and when to identify a patient who may not be responding. I like to reserve the term failure when it is actually fitting into the definition. I would not like to use it loosely. But it's very important that this regimen be prescribed in the right manner. Like I've said at previous meetings and previous other platforms, this is a regimen that works. We have seen in the country, if done properly in the right manner, this is giving us 90% plus success rate in our DRTB patients. So we would not like to lose even one of these drugs to resistance other than what we already have baseline. For example, fluoroquinolone, very small, minuscule percentage linezolid, but for bedaquiline and predominant, these are precious drugs, and the combination is working very well. So this is our own program data where we have success rate of more than 90%. So when we initiated it, people said you can never emulate the research data, which was 90 to 93%. But we have been able to emulate, and we're getting 90% plus treatment success rate. So for the sake of maintaining success of treatment in these MDR-TB patients, we are in fact carrying out we've had one round of regional meetings. We are starting a second round of regional level meetings where we will push the differentiated TB care agenda. We will train our peripheral level staffs, our DTOs, our program staffs in regional meetings, along with a revision of BPAL-M, so that mistakes in enrolling patients on BPAL-M do not happen. And early identification of patients who are not responding to BPAL-M and quickly need to be switched to another regimen is done. For this, we have equipped 42 labs to give us baseline DST to all the second lines. This you're all aware, I've said it more than once. And in addition, the centers of excellence are also doing targeted NGS. We will soon be able to scale it up. We're still in the initial stages. So with also we have the FDA staining, for which again 42 labs were trained, which was to discern between live and dead bacilli while the patient is on treatment. So this training also was imparted to all these 42 labs. Some of them are doing it well, some of them are catching up, but then these activities will definitely help us discern who's the patient responding, who's not responding, in addition to the clinical response, which the physician can obviously examine. So with these words, I thank the hosts again, and I think we can proceed with the case and we can take discussions later. Thank you.
Thank you. Yeah. I'm sorry, there is a electricity failure here, and we are trying to get rectified. Are you able to hear me, Dr. Rishi? Can you just give me an idea?
Yes, ma'am. Yes, ma'am.
Yeah.
It's clear, ma'am.
Thank you, thank you. So we carry on with our case. Today's case
Sure.
is from Uttar Pradesh, and Dr. Anil Kumar Yadav will be presenting the case, Failure to Fixes, Winning Difficult Clinical Battle. So that is what Dr. Anil Yadav will be presenting, and the state will be represented by Dr. Rishi Saxena, who is the Deputy State TB Officer at Lucknow, Uttar Pradesh. Our national expert will be Dr. Digambar Behra sir, who is a Padma Shri awardee. He is a professor emeritus at Department of Respiratory and Critical Care, critical care and sleep medicine at PGI Chandigarh. And our clinic expert will be Dr. Rupak Singla. So I request Dr. Anil to please present the case.
गुड आफ्टरनून। गुड आफ्टरनून डीडीजी मैम। सबको मेरी आवाज़ आ रही है?
आ रही डॉक्टर साहब।
हाँ, गुड आफ्टरनून टू एवरीवन। डीडीजी मैम, उपासना मैम, and Dr. Rupak sir and Rishi sir and my seniors. To myself as a Dr. Anil Yadav, the DTO Ghaziabad. I am presenting a difficult to treat today case. Just a minute. Hey, slide is not.
थोड़ा स्लाइड शो में कर दीजिए इसको।
Yes, yes, ma'am. Yes. Patient history, the comprehensive. Patient is a 30 years male and located in the resident Ghaziabad, Uttar Pradesh. As a education is a hold as a law bachelor degree, working as a lawyer in Supreme Court, India, and family structure living with his family with parents and in Sevi urban center. No family history of the TB and dietary history. He started intensive workout regimen, high protein diets, and November 2024 with the respect on me to lose body weight. Weight loss significant and unintentional weight loss 60 kg to 52 kg. Presenting symptoms the loss of appetite, fatigue, diarrhea, and daily activities. And
प्लीज
patient
सर इसको
also
प्रेजेंटेशन मोड में डाल दीजिए।
हाँ डॉक्टर साहब, प्रेजेंटेशन मोड पे कर दीजिए इसको।
एक सर प्रेजेंटेशन
ऊपर कर दीजिए, स्लाइड शो पे आ जाइए, स्लाइड शो पे आ जाइए।
एक मिनट
या नीचे से कर दीजिए स्लाइड शो पे। हियर हियर दिस इज स्लाइड शो।
ठीक है।
अभी आया नहीं है स्लाइड शो में डॉक्टर साहब, ऊपर सबसे ऊपर लिखा हुआ है स्लाइड शो लिखा हुआ है ना। इंसर्ट ड्रॉ डिजाइन ट्रांजिशन एनिमेशन स्लाइड शो लिखा हुआ है, स्लाइड शो पे क्लिक कर दीजिए उधर।
न्यू स्लाइड्स ड्रॉ डिजाइन।
नहीं यहाँ नहीं, यहाँ नहीं।
yes,
हाँ
yes,
यस यस, फ्रॉम द बिगनिंग कर दीजिए।
Okay.
बस स्लाइड
ठीक
शो अभी आया नहीं, अभी थोड़ा सा स्लाइड शो पे आया नहीं अभी आपका। हाँ ओके फाइन।
Okay. Patient presenting symptoms of loss of appetite, fatigue, body ache, and impact daily activity. And patient are losing the weight and intensely 68 to 52 kg. Patient also is history of the fever, low grade fever in January 2025. Patient complaining cough with sputum for 2 months, chest pain, and difficulty in breathing. Past history is a ocular TB, the DSTB at the age of 4 years and taken treatment for 9 months and declared TB completion. Initial, the patient was referred to the Rajan Babu, New Delhi for comprehensive evaluation. Sputum and gene expert in 13 February 2025. Rifampicin resistant and MTB is detected. And patient referred to Ghaziabad, the DRTB center, where they started the BPAL regimen at the 20 Feb 2025. Starting pre-treatment evaluation is all done. Conducted design and compressive pre-treatment evaluation was conducted at the designated drug-resistant tuberculosis DRTB center Ghaziabad. Include the clinical assessment, baseline laboratory investigations, and drug susceptibility testing and guide treatment. After that is started the beta-B-PAL regimen. The laboratory testing, the starting with gene expert 13 February 2025 the sample collection and 14 February the result MTB detected and rifampicin resistant. Then the sample again sent by the NITRD 19 February MTB detected rifampicin resistant isoniazid low and high dose पे resistant था। सेकेंड लाइन एलपीए की रिपोर्ट जो 19 कोई कलेक्शन हुआ था उसमें एमटीबी डिटेक्टेड लीवोफ्लॉक्सासिन रेसिस्टेंट मॉक्सीफ्लॉक्सासिन हाई एंड लो डोज पे रेसिस्टेंट था। सेकेंड लाइन इंजेक्टेबल इज अ सेंसिटिव एंड लो लेवल कैरामाइसिन इज अ सेंसिटिव। सेम फर्स्ट लाइन एलपीए का आईआरएल मेरठ में सैंपल भेजा गया इससे पहले 4 मार्च 2025 में 26 इसका रिजल्ट आया अप्रैल में 26 अप्रैल को, जिसमें एमटीबी डिटेक्टेड आया, रिफाम्सिन इन्फर्ड था, आइसोनियाजिड लो एन पे रेसिस्टेंट आया। इसकी जो कल्चर रिपोर्ट एनआईटीआरडी में जो हमारी 19 को फरवरी सैंपल कलेक्शन हुआ था, 4 मार्च को आया जो पॉजिटिव था। डीएसटीबी इथेनोमाइड से सेंसिटिव था, पैस से सेंसिटिव था, लिंजोलेट सेंसिटिव, क्लोफाजमीन से सेंसिटिव, बेटाक्लीन सेंसिटिव, डेलामाइड सेंसिटिव एंड मॉक्सीफ्लॉक्सन से सस्पेंड था। सेम इज उसके बाद फिर आईआरएल मेरठ रिपीट सैंपल कराया गया था जो 4 अप्रैल को, जो पॉजिटिव आया, जिसका रिजल्ट 18 जून को कलेक्ट किया गया। फिर उसके बाद सेकेंड लाइन एलपीए जो 29/4/25 को भेजा गया था। आईआरएल मेरिट एमटीबी डिटेक्टेड, लीवोफ्लॉक्सासिन रेसिस्टेंट, मॉक्सीफ्लॉक्सस रेसिस्टेंट, सेकेंड लाइन सेंसिटिव, लो लेवल कैनामाइसिन सेंसिटिव आया। फर्स्ट लाइन का सैंपल जो सेम किया गया तो उसमें एमटीबी डिटेक्टेड, रिफाम्सिन सेंसिटिव एंड आइसोनियाजिड आल्सो रेसिस्टेंट था। सेम 29 अप्रैल को सैंपल कलेक्शन किया गया कल्चर आईआरएल मेरठ पे, जो पॉजिटिव आया। आईआरएल मेरठ का उसके बाद फिर जून में भी भेजा गया सैंपल, वो भी पॉजिटिव था। सेकेंड लाइन एलपीए आईआरएल मेरठ द्वारा जो जून में किया गया उसमें सारे ही एमटीबी डिटेक्टेड था, लीवोफ्लॉक्सासिन रेसिस्टेंट, मॉक्सीफ्लॉक्सस रेसिस्टेंट था। एंड सेकेंड लाइन इंजेक्टेबल इज सेंसिटिव, आईआरएल मेरठ द्वारा 3 जून को जो किया गया उसमें एमटीबी डिटेक्टेड, रिफाम्सिन रेसिस्टेंट एलो था। सेम सैंपल की डीएसटी आगरा में लगाई है 28 जून को, जो जिसमें पैराजिनामाइड रेसिस्टेंट आया आगरा में। और 28/6 को जो सैंपल कलेक्शन किया गया था, जिसकी अगस्त में रिपोर्ट आई, मॉक्सीफ्लॉक्सासिन सस्पेक्ट सक्सेसफुल था। आईआरएल मेरठ द्वारा जुलाई में दोबारा से रिपीट कल्चर किया गया, वो भी पॉजिटिव आया। और आईआरएल मेरठ द्वारा 29 जुलाई 2025 को जो सैंपल कलेक्शन हुआ, जिसका अगस्त सितंबर में रिजल्ट आया, वो भी पॉजिटिव था। उसके बाद यहाँ से आईआरएल मेरठ के से ही सैंपल एनआईटीआरडी चेन्नई भेजा गया, जहाँ पे मॉक्सीफ्लॉक्सासिन रेसिस्टेंट था, क्लोफाजिमीन रेसिस्टेंट सक्सेसफुल था, लिंजोलेंट सक्सेसफुल था, बेडाक्लोइन भी सक्सेसफुल था। उसके बाद अभी रिपीट हमने 1 अगस्त को भी एक सैंपल कराया जिसमें स्पूटम का कराया, वो भी पॉजिटिव आया। ओवरऑल परसिस्टेंट कल्चर डिस्पाइट फुल रेजिमेन के बाद भी पॉजिटिव आते रहे। डिक्लेयर ट्रीटमेंट फेलियर किया गया इसका, क्योंकि इसमें जो रेसिस्टेंट आया था फाइनल, रिफॉर्मसिन रेसिस्टेंट, आइसोनियाजिड रेसिस्टेंट, फ्लोरोक्लोजिन रेसिस्टेंट, पैराजिनामाइड रेसिस्टेंट। सेंसिटिविटी थी बेडाक्विलिन, डेलामाइड, क्लोफाजमीन, लिंजोलेट, पास एंड एथ्योनामाइड एंड कैनामाइसिस। यानी कि जितना हमारा बी पाल का रेजीम था वो सारा ही पॉजिटिव था, मतलब सेंसिटिव था। उसके बावजूद भी कंसिस्टेंट स्टार्टिंग से लेकर लास्ट तक सारे ही टेस्ट में वो सिर्फ पॉजिटिव आया, एमटीबी डिटेक्टेड था और सबसे रेसिस्टेंट आया। जो मेडिसिन हम चला रहे थे उनसे सेंसिटिव था। अगर हम बात करें एक्सरे की बात करें तो ये 4 जून का 2025 का एक्सरे है। उसके बाद हमने रिपीट किया उसका जून में और जुलाई में भी। तो एक्सरे में जो फाइंडिंग्स लेफ्ट साइड में ही आ रही हैं, मगर एक्सरे से ज़्यादा जो हमारी मेन फाइंडिंग जो सीटी स्कैन में आई है हमारी, 8-6 जून को जो हमने सीटी स्कैन कराया, या उससे पहले भी 8-6 जून को कराया गया, उसमें भी हमारी 8/6/2025 को, जिसमें कैविटीज आ रही थी। और उसके बाद जो रिपीट में हमने लास्ट में जो हमने अगस्त में 1 अगस्त को कराया, उसमें भी हमारी कंसिस्टेंट जो लेफ्ट साइड में पूरी कैविटी नजर आ रही थी, पूरा होल कवर किया था। यानी पेशेंट का अगर देखा जाए, स्टेटस देखा जाए, तो पेशेंट ओवरऑल वेल है, पूरी तरीके से ठीक है, सिम्टोमेटिक कोई सिम्टम नहीं है प्रेजेंट टाइम में था जब जब था। मतलब कंसिस्टेंट टेस्ट हमारे हमेशा पॉजिटिव आया है, एमटीबी डिटेक्टेड आया है, सारे इसके कल्चर पॉजिटिव आए हैं। उसके बाद फिर हमने अपना रेजीम को चेंज किया 20 सितंबर 2025 को। उस टाइम में हमारा जो वेट था 20 सितंबर को 65 kg था। आज की डेट में उसका वेट है 69 kg। जो स्टार्ट करने के बाद जो हमारा रेजीम था नया, उसमें हमने बेडाक्विलिन, क्लोफाजिमीन और साइक्लोसिन, लिंजोरिड और डेलामाइड का स्टार्ट किया। ये सारी चीज़ें और पेशेंट स्टिल हैविंग कफ ऑफ इधर 14 अक्टूबर 2025, but till date patient has not any cough, अगेन गेनिंग वेट। पेशेंट रूटीन एक्सरसाइज करता है, वो जिम्स पे जाता है और वेट एक्सरसाइज भी करता है। दीज केसेस एलिगेशन इनहेरिटेड कंप्लेसेंट मैनेजमेंटिंग pre-existing drug resistant tuberculosis despite an initial aggressive therapeutic approach b palliative regimen, patient consistently exhibit microbiology positivity, critically reevaluation treatment is Today's discussion point क्या re-evaluate the treatment adherence, incorporate strategy, reinforce compliance, and considering therapeutic monitoring, assess the pharmacokinetic, ensure the adequate drug labels, perform repeat DST2 for the bedaquiline, delamide, and certain resistant pattern. रिपीट डीएसटी कराई गई, वो भी अलग अलग लैब पे कराई गई, ऐसा कोई वो नहीं था कि एज ए ह्यूमन एरर कि पेशेंट और सिम्टोमेटिक इंप्रूव हो रहा है, मगर ये कंसिस्टेंट है, इसलिए हमने अलग अलग लैब से भी कराया, प्राइवेट लैब से भी कराया, ऑल में सब में हमारा पॉजिटिविटी आ रही थी। डिसवीन लॉन्गर रेजीमेन अकॉर्डिंग टू डीएसटी के बाद हम लोगों ने चेंज किया। एक क्वेश्चन था कि ऐसे केसेस में होल सेल जीनोम सीक्वेंसिंग करानी चाहिए, क्योंकि इससे पहले हमने डीएसटीबी के केस में एक प्राइवेट से हम लोगों ने कराया था जिसमें ट्यूबरकुलर लिम्फेनाइटिस थी। बार बार कराने के बाद भी उसमें ट्यूबरकुलर लिम्फेनाइटिस में कोई रिस्पांस नहीं आ रहा था। बाद में हमने कल्चर भी कराया उसका, पस का कोई रिस्पांस नहीं आया। उसके बाद हमने होल सेल जीनोम सीक्वेंसिंग कराई, आईआईटी का एक प्रोजेक्ट था उसके थ्रू, जिसमें पॉजिटिव आया, हमने ट्रीटमेंट चेंज किया और पेशेंट को बहुत रिलीफ आया। तो क्या यहाँ पे होल सेल जीनोम सीक्वेंसिंग करानी चाहिए? और रेफर टू रिव्यू द पेशेंट के स्टेट, द ड्रग रेसिस्टेंट कमिटी एंड नेशनल इंस्टीट्यूट ऑफ एनआईटीआरडी expert opinion to comprehensive management and guidance. In implemented comprehensive psychological and nutritional support interventions, address patient well-being and mitigate the adverse effect and enhance overall treatment outcome. Next step, the baseline comprehensive drug sensitivity, results of sensitive drugs, patient monitoring, sputum culture consistently किए जा रहे हैं आईआर मेरठ द्वारा भी, रेगुलर फॉलोअप किया जा रहा है DRTC गाजियाबाद के थ्रू, एंड साइकोलॉजिकल सपोर्ट भी हमारी कंसिस्टेंट टीम फॉलोअप करे, क्योंकि हमारा पहला केस था बीपालएम का, तो कंसिस्टेंट हमने सारे ही टेस्ट कराए हैं, इसके पूरा फॉलोअप किया, उसके बाद भी फेलियर है। नाउ इज द केस फॉर डिस्कशन। थैंक यू।
Thank you, Dr. Anil. There are some questions in the chat box regarding the case. And if there are any burning questions regarding the history, you may ask the questions. I will just give you a brief history what Dr. Anil has presented, because almost 30 people have joined after your presentation has started. So this is basically a young male of 31 years who came with complaint of fever, cough, chest pain, loss of weight, and he has been diagnosed with various tests. The LPA and CBNAT and your liquid culture DSC has shown resistant to rifampicin, INH, fluoroquinolones, and pyrazinamide. Patient was put on BPAL M regime on 25th February, and he has been consistently culture positive during the treatment. And now the treatment regime has been changed to bedaquiline with delaminate, cycloserine, clofa, linezolid from 20th September. So we may take the questions from the chat.
Yes, ma'am. There are questions from Urvashi, ma'am. So, what was the dose of the treatment you started on Bipal, and what was the dose in Bipal which you
So
were given?
before that, Dr. Meena, my question is, what were the inclusion exclusion criteria carefully looked at? Because he's not mentioned anything about that.
Yes, ma'am.
ओके मैम, इसमें बेसिकली इसका हमने बीपालएम का पूरा क्राइटेरिया फॉलो किया था। एज 14 ईयर से ऊपर थी, हमने उसके पूरा प्री ट्रीटमेंट एवोल्यूशन भी कराया, रिफाम्सिन रेसिस्टेंट था,
Sorry
उससे
to
उससे पहले कभी उससे पहले कभी भी बेडाक्विलीन पेटेनॉइड से एक्सपोजर नहीं था।
Dr. Anil,
यस यस।
request to speak in English because there are some people who have joined from South. So they
ओके ओके ओके।
requested to speak in English. Sorry.
During my starting phase, I will start at the pre-treatment evaluation. Patient is the age is the more than 14 years and rifampicin resistant, no exposure to bedaquiline and pretinoid and linezolid. So I will start the treatment as a BPAL, and only is a one lung se, but only the left lung is involvement.
Right.
What will be
During treatment phase, patient not showing any adverse effect, patient not taking any drugs, जिससे that से affect the therapeutic level of the drugs, and I think the follows all criterias.
Dr. Anil, how do you see for adherence? How was the adherence ensured?
Adherence, basically patient is a directly come, patient is a very conscious regarding to your health, and patient will directly come, and my team is also come and follow all the treatment. हमने and every moment I will the full follow up like is the first line. हमने starting में as the sample is collected in the 19 February the 2025 and send the sample and all are the detected during this phase also the phase and DSTB sample is also collected in 19 February. जिसमें all of the sensitive regarding the linezolid sensitive, clofazimine sensitive, bedaquiline sensitive, and delamide bedaquiline sensitive. All the three drugs are the sensitive. So there is a no issue in the any drug or any criteria which is not following in case of the BPALM. After that, I'm a regular X-rays and CT scan is also done. But patient is already gaining the weight, relieving the symptoms like the fever and gaining the weight. And after that, consistently, I think that the human error patient is symptomatic is improving, but not improving in the results. So and again, in test done in different labs like as IRL, Meerut, and Agra, and NITID, Delhi, and NIT Chennai, all are the positive.
Now, the first question I have was, did you rule out any extrapulmonary site involvement?
Yes, ma'am.
So you've
I
not
am.
mentioned that. You've not mentioned that. And prior exposure to drugs, you did mention probably.
नहीं, ma'am,
I
starting
have an issue with 2 weeks delay in initiating treatment.
नहीं मैम I will 13 February 2025 is the patient is a confirm the rifampicin resistant and MTB is detected refer from the Rajan Babu Pram to DRTB center Ghaziabad. I will start it the 20 Feb 2025 within a week I will start the treatment.
Yeah, so within a week, somebody wrote within 2 weeks. So within a week भी क्यों लगा? उससे जल्दी आप कर सकते हैं. We do not
Basically,
need.
when patient come during this phase, the February is the main regime is not available during this time. So I am ordered to in
See, what
Lucknow
we
and
have advised these sites is once they identify MDR-TB, using Rajan Babu Institute did identify,
yes,
they
sir.
will initiate, give the treatment for the first week or two till the patient is transferred to the district where he'll take treatment in the follow-up. So
Ma'am,
that is the standing direction. If that was not done, we will have to ask from DTO, RBI, PMT why this was not done, right? Now, bringing you back to the history, you have said as a 4-year-old child, the patient had had ocular
ocular
TB
TB.
for which he took 9 months treatment and was declared as cured, treatment completed or cured.
Yes.
So that did not bother you that there could be a possibility of any extrapulmonary involvement, and that could be one reason that the patient is not responding to the BPALM, because BPALM
I'm
is not recommended for such patients. Ji, boli.
basically I'm the rule out the old chest X-ray. Nothing is any extra pulmonary TB. Only the lung is involvement. I no symptom is ocular TB. This is the present time. Everything is normal except the lung is only involvement this time. Then I will start the treatment.
Dr. Singla, sir, could you go through? I don't know if Dr. Mattu has been able to join, or either you or Dr. Mattu can go through the inclusion exclusions for the sake of completion now.
Yeah, good afternoon, Dr. Rishi. I hope you're doing well. So, you see, but it's very important that we have raised from the beginning itself in your initial address that before we start patient on BPLM, we need to see that there should not be any exclusion criteria. Only then we need to start. So, for the initial inclusions are patient should be rifampicin resistance. Even if there is a fluoroquinolone resistance, that is not an exclusion criteria. Severe pulmonary TB, extensive pulmonary TB is not an exclusion, but severe EPTB like CNS TB, bone TB, meningeal TB, miliary TB, or disseminated TB in more than one organ, more than two organs, is an exclusion criteria. So that also we need to see whether patient was having any of these exclusion criteria. Plus, patients who have taken bedaquiline, predominant linezolid in the past for more than 1 month, they are to be excluded unless we have a DST from a certified lab showing that they are still sensitive. Otherwise, we need to exclude them. In these cases, pregnancy is an exclusion criteria unless patient is ready for MTP. And the other things like we have the laboratory parameters. If the dual function test, there are figures given for that. That more than 3 times in case patient is symptomatic or more than 5 times in case patient is asymptomatic, they are also to be excluded. Then the ECG criteria QTCF in males more than 450 milliseconds, female more than 470 milliseconds. If they are there, again patient is not to be put on this. Then actually now you see I'm just speaking the extempore. So these are the main things which we need to. Of course, the age should be 14 years or more. Anybody less than 14 years of age, BPLM is not indicated. So these are the main things which need to evaluate. And I think in this case, although patient had the ocular TB at the age of 4 years, but presently, as we are being informed, patient primarily had chest symptoms. X-ray chest was done and CT scan chest has been done. So there is no other obvious evidence of extrapulmonary dissemination of the TB.
So I think, sir, what is very important today, and I think I've been hearing that in UP, this practice of over eagerly putting patients on BPAL-M is going on. It is important that inclusion exclusion should be thought of carefully. Patient, that is the pre-treatment evaluation one should do. One should not lose any time in initiating treatment. We do not need FQ sensitivity. We do not need to look at FQ sensitive and FQ resistant. In fact, there's so many times the culture and DST has been done. I think it's a wastage of resources. Also, there were one or two other thoughts on my mind that, the patient lost a lot of time from February till September, till he was actually offered the longer regimen, which is again something we should worry about. And this is why we had clearly trained this 42 labs were trained in doing FDA staining in the month of January or February. So Dr. Nishant is with me, who looks after the lab. An intensive exercise with help from NIRT was done, where these labs were trained. Again, no other country does bedaquiline predominant DST. We are the first ones to do it, and our labs are well trained in it. We also train labs to do FDA, which will discern live and dead bacteria. During the follow-up initial period only, we could have caught that the patient was not responding. We should have switched the patient earlier. So time is of essence, because the patient who's growing on culture is also disseminating into his community, to his contacts. So the public health action, as is the word used, has not been taken care of. A lot of time has been wasted sending sample to one lab, to another lab. Why do you doubt your NRL? You're sending to a second lab and third lab. And then the speaker also said whole genome sequencing helped. I do not know why whole genome sequencing at this point could have been helpful to you. If phenotypic DST always remains the gold standard, whole genome sequencing, when available, when the number of bacterial or the bacterial load is adequate, at baseline, when before initiating treatment, before phenotypic DST is available to you, that WGS or targeted NGS, as we have rolled out under the program, can be handy to you. So we should not talk about fashion when our function is so slow. We are initiating patients after 2 weeks of diagnosis. We are initiating him wrongly. If he is a known case of ocular TB, he could have had other sites involved, a reactivation possibly. And 4 to now, he's probably 30 years or something. So he can always have a reactivation, and very important to rule out extrapulmonary TB. And the right regimen, the right dose. If the patient is gaining weight, change the dose. Those kind of basic things are important, rather than doubting your NRL, which is giving you the right result, running hither, trying to look for. So, of course, the discussions can go on. But then these are few things that could have been taken care of, and possibly we can come back with more. Thank you so much for the opportunity to speak.
Thank you, ma'am. Thank you so much.
Regarding this,
there's a question in the chat box. Does pulmonary lesion with cervical lymphadenopathy classify for dissemination or not? It's a question for you.
Yes, you see, this particular question, whether somebody, if he has
Sir, your mic is mute, sir.
Okay, I'm sorry. So the question of having pulmonary tuberculosis and a cervical lymph node, which is again tubercular, if this should be treated as disseminated or not. You see, as of today, as per the current understanding, this means there are two sites, pulmonary lesion and the lymph node lesion. They are to be treated as disseminated. And also, let me tell you, most of the time we have seen, like in our institute, because we have the luxury of having this ultrasound and other things, when we investigate a cervical lymph node, we do look at the mediastinum from the X-ray itself, and if there is a doubt, we even get the CT scan done. But most of the time, X-ray itself also tells us whether there is a mediastinal lymphadenopathy or not. And then we look at the abdomen also for any lymph nodes. And many a times, the cervical lymph node is associated with mediastinal and or abdominal lymph nodes. So, as per the current understanding, the pulmonary TB with cervical lymph node TB is to be taken as disseminated TB. Although there are clinicians who are saying that in case we have only cervical lymph node, small cervical lymph node with pulmonary TB, it may not be taken as disseminated TB and may not be excluded from BPLM. But as per the current guidelines, it is to be taken as disseminated and not to be initiated on BPLM. That is my understanding. Thank you.
Thank you. We have a hand raised from Dr. Mattu. Yes, sir.
Thank you, madam, and thank you, Dr. Singla, sir, for explaining. Am I audible?
Yes, sir, you are.
Sir.
So, actually, I joined this session late. Initial part was missed. When we said first is some information I will need about this failure of the BPALM. When it was started on the BPALM and then declared failure. So, what was the failure criteria? If you may give that explanation, and then I will make my comment.
Right, sir. Thank you, sir.
No problem.
So now we go to Dr. Rishi, sir, who will.
Yes, ma'am. Yes, ma'am.
Achha, I think Dr. Mattu asked Dr. Anil a question. Dr. Anil, please.
Yes, sir. एक minute.
When it was started on the BPALM, what is the criteria to declare it as a failure?
Maybe I will start at the exact government say the
February.
28 February.
28 February.
the treatment initiation date of 20 February 2025. After that, the first line LPA and the first culture report. The first culture reports is a positive after the in February, and again the after 2 months treatment completion के बाद भी culture is a IRL merit is also is a positive, and consistent 4 months is a positive. Then
So baseline DST report, what was the baseline?
yes, the
DST
baseline
report?
DST is also done.
What was the report?
The report is the ethionamide is sensitive, PAS sensitive, linezolid sensitive, clofazimine sensitive, bedaquiline sensitive, delamine sensitive, and moxifloxacin sensitive. All B-PAL medicine are the sensitive.
Okay. And a consecutive 4 month you took the sample,
Yes, yes.
and a 4 month sample was DST, this culture report was available by what time?
Yes. Fourth is and again 2, 3, 4. Last culture report is the sample is goes on first June, 1st July 2025, and collection date is August. Is the positive.
Okay. Continuous positive in the all the 4 samples, and the 4th sample which was collected in the July, the report came in August, right?
Yes, yes.
And it was again positive.
Yes.
Okay, so like Dr. Sungla sir were mentioning, we need to consider this part. Whenever more than one organ is involved, we call it as a disseminated as per the current definition. And questions remains as sir was mentioning, like if it is a hilar lymphadenopathy, we need to consider it is a disseminated or not. That question remains still there because many times when we are saying this gone complex other things, because that is there, which is the initial involvement of the this primary infection is there, and then the secondary infection occurs. So we need to consider that in perspective, but I agree with somehow Dr. Singla sir's opinion, like if it is more than one organ, it may fall in the category of the disseminated TB, and disseminated TB is a contraindication for BPALM. So at the first place, we need to have the detailed consultation whenever more than one organ is there under nodal DRTB centers. If patient may be fit into these kind of regimens or the BPALM regimen, if patient would have been fit into. Though this is one thing. And so, sir, as you are saying, Dr. Singla, sir, that it was mediastinal or hilar lymphadenopathy. What exactly it was?
You see, I think there is some miscommunication. The question was whether if a patient has pulmonary TB and cervical lymph node, should it be treated as disseminated or not? That was the question. And when we were discussing the question, we said as of today, the current understanding is pulmonary TB with cervical TB, cervical gland TB, is to be treated as disseminated and not to be put on BPLM. In this case, cervical lymph node was not there. Let me clarify. And then in the same context, I said that whenever we have cervical lymph node TB, as a routine, because this is a continuity of a chain, we look at the mediastinum, we look at the abdominal also. And many a times we find with cervical, mediastinal glands are there and abdominal glands are there. So that this again sort of justifies to take cervical TB with pulmonary TB as disseminated TB. But sometimes we have documented evidence of only cervical TB without any mediastinum or abdominal TB. So there the concern comes, does this case really deserve to be put out of BPLM or not? But clearly the current understanding is cervical not even alone with pulmonary TB should be treated as disseminated TB and not to put on BPLM. So that was the whole discussion.
Yeah, that's fine, sir. You are absolutely right. Like if it is a cervical lymphadenopathy along with the pulmonary TB, because lymph node we usually when it is cervical lymph node or other than this hilar node, it can be definitely considered more than one organ and has to be disseminated. This is one thing. Other thing, sir, like when you are suggesting if pulmonary TB is there and person is to be there in the pre-treatment evaluation, in that actually if abdominal ultrasonography or the scanning is to be done for the lymphadenopathy, somehow that was not part of PT, so we need to revisit that part. And as we are developing our comprehensive DRTB book, so that has to be elaborated in that book. Otherwise at the peripheral level, whatever goes, they see through those lenses only and they restrict to what is written in the book. So somehow we miss this part, as you're suggesting that a person need to be ruled out for dissemination, and for that there might be needing some abdominal scanning may be needed.
No, no, let me clarify. I did not say that every case of PTB should have abdominal ultrasound because definitely all of us are aware that cannot be done in the periphery and we are not even recommending it. It was just an observation that if somebody has cervical glands and we look for these things, we find that they are there. And that was the reason to explain that cervical lymph node with pulmonary TB should be taken as disseminated TB. But of course, under the national program, as per the current guidelines, we are not expected to do ultrasound or CT scan chest in patients of pulmonary TB as a routine. So that message should be quite clear to all the people attending this clinic. Thank you.
There is one more question in the chat box. If the patient has a delayed response in case of cervical lymph node TB, shall we extend the BPALM regimen from
No.
26 weeks to further? Or there's a delayed response. Response is there, but there's a delayed response, not complete resolution of lymph node cell.
I think these kind of this question will take it once we discuss the present case. Because I think let us restrict to the current case first. During the discussion, we will discuss when to extend, how much to extend, and all these features. So let us.
I would just like to bring another angle. Has the lab ruled out non-tubercular mycobacteria? Because if without, confirming it as MTB, if they go on to do DST, they will report DST. So is that report confirmed? That is another angle. It could be non-tubercular mycobacterial infection in the lungs. May not be in this case because we know past history, we know cervical involvement, but of course, that is one angle one should always keep in mind. And I think we'll let the presenters complete and bring back the discussion.
Thank you. Thank you, Dr. Mattu sir, Urvashi ma'am, and Dr. Singla. So I now request Dr. Rishi Saxena sir to present the case as the state expert.
There is one more opinion
thank you.
in this. Okay, actually, a discussion on this case will occur now. So I will give my input later on about this case. Yeah, please go ahead.
Thank you, sir. Thank you, ma'am. Regarding this case, just the points which have to focus on that he's a health conscious 31 years Supreme Court lawyer who is also son of a lawyer. BMI is 23.5. He has no family history of TB, no comorbidity, no HIV.
Slides.
But has
Rishi, your slides are not moving.
Just a minute, sir. Okay. Just a minute, sir. Okay. That's a problem. It is now moving or not? Just stop share. Just a minute. Hold on. Just a minute, sir. Stop share. Stop share. Share. Correct slide. Sir, now it is same, sir.
नहीं सर, आप फुल स्क्रीन करके और फिर सेकंड स्लाइड पे जाइए. हाँ, now it is okay.
Okay. So, current slide. Now it's clear, madam?
Yes, sir.
Okay. So the points in this case is that this summary of this case where he's a health conscious, also a good Supreme Court lawyer also. BMI is 23.1, no family history of TB, no comorbidity, no HIV. He had ocular tuberculosis only, and his treatment was completed in, I would say, since he is now 31, at the age of, during 1998. He might be having DSTB treatment for this case, and his treatment was completed. Now, again, he developed in January 25 riff-resistant. The DST shows that he was sensitive to all, and moxie is resistant, as he told me. If it doesn't matter whether it is resistant or sensitive, doesn't matter. So the BPAL-M was started on February 25. And in spite of complete adherence and timely follow-up, the cultures were sent. The reports of these cultures are, as you are seeing, on 19th Feb, 29th April, 3rd June, 1st July, 29th July. They are all positive. Even the HR
Dr. Rishi's voice is lost, or is it a problem at my end only?
नहीं सर, I
Pardon,
think
sir?
आपकी आवाज नहीं आ रही थी सर बीच में.
Hello, sir.
हाँ. So can you, Dr. Rishi, you can start from
Sir,
the.
all this culture.
हाँ. So we should hear you बीच में.
X-ray, okay.
X-ray से. हाँ.
Acha. Sir, madam, these are the points where it shows the complete history, what was done. The patient is totally a health conscious patient. He has no family history of TB, no comorbidity, no HIV was negative. Ocular TB he had. In 1998, he was treated with the DSTB treatment and was completed. He again developed riff resistant in January 25. And for this, since the age is 31 years, riff resistance was there. The baseline DST shows trends and timely follow-up cultures. These are the dates we are seeing almost 5 cultures, and they are all positive. Besides this, the X-ray and the HRCT also shows increased heterogeneous opacities in the left lung, probably in the
I think there is some technical issue from Dr. Rishi's side.
failure.
Dr. Rishi, आप वीडियो ऑफ कर दो, इस बीच में आवाज जा रही है आपकी. तो
Voice is breaking.
मैडम आवाज ओके.
हाँ, आप वीडियो ऑफ कर दीजिए. हाँ, अब
ओके मैम, ओके. Okay, ma'am. Video forget. Okay, ma'am. Just a minute. And madam, the similar type of case was also presented on 22nd January from UP, where the child was of age and he was resistant, but complete adherence. But repeated tests was found to be positive. So at that time, therapeutic drug level monitoring was done, and there it was found that the drugs of rifampicin, isoniazid, and paracetamide were low as compared to the therapeutic levels were low. So from this discussion, now the current status of that patient is that on 15th February the culture was positive, but subsequently 15th September and 27th culture was negative. And is doing fine and the treatment is being continued. So now in this case, the causes, the possibilities for treatment failure by ATT drugs, whether drug sensitive TB or drug resistant TB, with complete schedule follow up and complete adherence, might be that.
Slides not moving. Slide not moving.
Sir. Okay. Just a minute, sir. Okay. Just a minute, madam. Share. कहाँ गया यार? Some problem with the net is there. Stop share. Share. So now is this? So now it is seen, sir. Madam.
Slide number 5. It is slide number 5.
Slide is being shown, madam. Hello.
Slide is there.
So ऋषि आपकी slide तो देख रही है? Now we can see the slide.
Slide number 5. Okay.
Slide. This is
4.
Slide.
This is the slide says causes.
Slide number 4 is
causes possibilities of treatment failure.
Sir.
डॉक्टर ऋषि अभी भी प्रेजेंटेशन मोड पे नहीं है.
Sir, आवाज okay. Something internet problem is with sir. Yes, sir. Sir, कर रहा हूँ. HOPE hope start 0 to 5. Next. Sir, wait a minute, sir. I'm again sharing the slides, sir.
डॉक्टर ऋषि आप ऐसे करिए स्लाइड जो स्लाइड या तो मुझे या डॉक्टर नीता को भिजवा दीजिए. वी विल आस्क अवर टेक टीम टू प्रेजेंट.
ठीक सर, ठीक. ओके सर, ओके सर. I'm sharing.
हाँ.
Just a minute, sir. Sir, just a minute, sir. Center slides.
अरे ऋषि
सर सर
नीचे एक ये जहाँ लार्ज इनलार्ज होता है नीचे नीचे जाइए उसमें एक कप बना हुआ है उस कप को क्लिक कीजिए स्क्रीन फुल स्क्रीन आ जाएगी एंड मूव अप एंड डाउन दैट इज सिंपल.
ओके सर आई हैव डन सर.
या देयर इज ए बिलो राइट साइड में एक कप दिख रहा है उस कप
सर क्लियर हो गया सर. यस सर.
कप को क्लिक करें स्लाइड पूरे उसमें आ जाएगी.
सर आगे देखिए सर आगे सर ये
नहीं
there is some problem at his end. There is some problem.
Yes, your cursor is going down. Yes.
Okay sir.
आप नीचे जाइए कोने में वहाँ एक कप दिखेगा जहाँ इसको हम स्लाइड को अप एंड डाउन करते हैं वहाँ इस कप को क्लिक करिए आपकी स्लाइड
trophy.
फुल स्क्रीन पे आ जाएगा।
सर ये आ रहा है सर, नहीं आ रहा सर अभी?
नहीं आ रहा है।
अरे सर जस्ट अ मिनट सर, some problem is there, I am sorry sir, just a minute sir. सर ये आ रहा है सर? सर ये
आ रहा है, it's
ठीक
clear.
सर, ओके सर,
It
ओके
is
सर,
second slide now. Causes
ओके सर,
interruption.
सर सर आई एम सॉरी सर. तो सर बेसिकली द रीजन फॉर this in this case, what are the probabilities, what are the possibilities that in this case, in spite of complete drug adherence, the follow-ups cultures are positive. So the reasons might be like number one is malabsorption. In this case, we can switch to from oral to intravenous, which may at times is helpful. Drug interactions is also there, like strong inducers of cytochrome. Then acquired drug resistance might develop during the BPAL course. Then persistent bacteria within the granuloma is also seen, but it is mostly seen in those cases where the lungs have cavities. Then coming to the next part, we have to increase the dose also, and at times there are comorbidities also sometimes. So inadequate dosing can also lead to failure. Then there is we say a biofilm formation. At times what happens is that the mycobacterium sticks to another bacteria, and it creates a exopolysaccharide capsule type formation, which protects that bacteria. So the film polysaccharide capsule in where the bacteria is there. So it happens. Then the other reason, then extensive or severe disease may also be there if there is a high bacterial load. So all these cases might be a reason for possibilities of culture positive in spite of complete adherence. So in that case, in such cases, I think the therapeutic drug monitoring may be done, which may helpful in such cases whether we are underdosing, yeah, we are overdosing. So or we can also change the drugs also because of internal metabolism might be there. So these are the cases. And after therapeutic interventions, we can adjust the dose or we can switch the routes of administration like from oral to IV, and we can even revert to standard dose if the dose is high, yeah, low. And so it depends upon the weight of the bacteria of the patient also. So malabsorption may be corrected with the standard dose also. I'm sorry that this is all my presentation from my.
Thank you, Dr. Rishi. There were many technical errors, but still you carried on. Thank you so much. Now I request our national expert, Dr. Behra sir, for his comments. Dr. Behra sir. Meanwhile, Dr. Matu sir, can we take your comments?
Actually, madam, as highlighted by, this was one of the points from my side. Am I audible?
Yes, sir.
I was suggesting, as Dr. Rishi already in one of slide mentioned, because initial DST report showed that all the BPALM medicines were sensitive. So bacteria was sensitive, so that was one of my concern, if the blood concentration or the concentration which is needed to act on the bacilli is reaching or not. So TDM was one suggestion which was highlighted, but I don't know if the UP team has tried to do that TDM testing or not, if lab facilities were there or not. So that was my question and input, if they can share, like if they have tried it or not, to see the TDM. Definitely If TDM facilities are not there, then definitely course will be we need to switch over the regimen which is next available regimen. But still, if the facilities are there, that may be tried to know if this therapeutic concentration are maintained or not. That was one suggestion, and it was highlighted in Dr. Rishi's presentation also. Over.
Thank you, sir. So, Dr. Anil, is it done, the TDM for this patient? Therapeutic drug monitoring?
Ma'am, repeat, ma'am.
So, therapeutic drug monitoring, have you done for this
No,
patient?
no, ma'am, no. That facility is not available. I'm clear the some points. Starting with the raise, there was a patient not existing any symptom indicating involvement any body part. So there is a no need to whole body scan. Just starting with some point is already raised, and some point is raised ki why the DST is repeated again and again. The first sample was taken at the NITRD, which we are not aware. We need the CB net has been only done. So we send the patient sample in Merit. Merit then sent to sample the Agra due to some confusion, and DST is not available. Then IR Merit repeats again and again.
So you
This
mean
is the
to
only
say
reason.
same sample was sent to 2-3 labs?
And one thing is also starting with the inclusion criteria, patient is the more than 14 year, only is a lung involvement, no other body part is an involvement, and CBC is a normal, lymphocyte count, LFT is normal, Namata is not any exclusion criteria, and in RFT is not an exclusion criteria. All inclusion criteria is present that time. So started the BPALM regimen. During the phase, patient referred to Delhi to Ghaziabad takes time, the more than 1 week. Patient taking time, patient is not come to the center. So that is a gap between the 1 week for the starting the treatment. That's not for the DRT center Ghaziabad.
Thank you, sir.
Okay.
One more thing, Dr. Anil, have the team tried to rule out the NTM as was suggested by DDG TV?
Yeah, ma'am.
Have the any lab tried to rule out this NTM part in this case as suggested by DDG TV?
Yes. This is a only the myobacterium tuberculosis is detect, not a non-tubercular bacteria. Is clear.
Okay.
Thank you, Dr. Anil. Dr. Behra has joined us. So now I request Dr. Behra sir to give his comments. Dr. Behra sir.
He was just here now. He was just here. I saw him.
No, he is there, sir. I think sir is busy. We can see him on the cam, but sir seems to be busy. So are there any more questions for the presenter? Yes, Dr. Rajiv.
Yes, I have one query to Dr. Yadav. How he has labeled some ocular TB detected almost 3 decades back as a drug-sensitive TB. He has not mentioned this in his presentation. Second is,
See, patient only gives, yeah, patient is only give history ki he have during age of 4 year, ki the ocular TB is present, but no any documentation is present. So no idea is.
you have mentioned that it was a drug-sensitive TB. It means some
Yes, the
kind
drug sensitive TB because starting the he's
no,
showing the
it
some
was not
medicines the DSTB only.
responded to first-line ATT. It
Yes.
was not DST. That is what you
Sir,
mean to say.
sir, at that time, sir, I'm audible, sir.
हाँ जी ऋषि सर आपकी आवाज आ रही है.
Sir, because he sir इसकी age है at 4 years of age. So if we calculate from this age from 90, if he was born in 94, so by the age of I would say 1998, he might have contracted this ocular TB. And at that time, sir, I don't think the only DSTB treatment was given, sir.
इसीलिए प्रेजेंटेशन में इसको DSTB की जगह केवल ऑक्यूलर टीबी बोलना चाहिए था सर. कोई ऐसी बहुत बड़ा इसमें कोई प्रॉब्लम नहीं है. जो मेरी इशू है मैं सिंगला सर से उसके बारे में सर की ओपिनियन जानना चाहूंगा. What as TB practitioner we are aware of that somebody who has been diagnosed and treated for tuberculosis may have in future pulmonary or extrapulmonary reactivation. Here, a case of ocular TB seemingly being treated successfully. Dr. Upasana is, the DDG ma'am is suspecting that the ocular TB has reactivated as pulmonary TB. So I would like Dr. Singla's opinion on this. And I will also like to know from Dr. Singla why in a persisting patient who is persisting with MTB in his sputum, the issue of NTM is being raised, and how does this affect the clinical status? And fourth is why TDM would be done in a patient where Dr. Yadav has been repeatedly saying that the patient is healthy, and he has also claimed a possible weight gain in this patient. Thank you.
Yeah, Dr. Rajeev, your comments are well taken. And regarding the other point we'll be discussing soon. And regarding why the NTM was considered or not considered, I think Dr. Urvashi had raised this issue. So I'll request Madam to reply to this query from Dr. Rajeev.
Sir, if I go into the details, the basic science details, of course, there can be reactivation and reinfection. So this case, because it's a known case of past TB, reactivations are clearly known. And in fact, in our risk groups, we include patients who had TB in the past as one of the risk groups. So reactivation cannot be, disproven. And having ocular TB is always the source of entry is through the mucosa of the respiratory tract, unless there is another mucosa where it can enter from. So it must have been, involvement of more than one organ when he was 4 years old. It is possible that the same disease got reactivated or he picked a fresh reinfection. Now, that is as far as the reactivation reaction is concerned, and the only way to disprove this would be probably genotypic. And again, there's a scientific debate now that disease is always polyclonal. Hence, to prove genotypic association of a reactivation with a prior infection is also very tricky. Now, when NTM thing came up, the point I was trying to make was there are reports from good labs where they have not confirmed the culture as Mycobacterium tuberculosis complex, because there is a step of that confirmation once the culture grows. If you do not do that confirmation, the NTM and MTB grow in a similar manner, and the DST of these, especially the slow-growing NTMs, are done in the same manner as the DST for MTB. Hence, we may be dealing with a non-tubercular mycobacteria if the lab has missed. But in this case, the NRL has done it. The NRL would have followed the guidelines. So I do not doubt it. I only wanted to bring up that do not forget NTM, because though India does not report, for the sake of publication, not so many publications are available, but it is a clearly defined cause of pulmonary as well as extrapulmonary disease. In fact, we know exactly what is the frequency of abscesses is coming more often than MAI, then Kansasai. If you look at the ATS guidelines, it talks of avium being most common, followed by Kansasai, followed by abscesses. But in India, what we are finding at AIIMS, we had a series of, more than 100 cases where we were finding abscesses as predominant. So one must keep one's, perspective wider. And if the lab, like in this case, have been good labs, would have definitely confirmed MTB. But in the past, such reports have been seen where MTB complex was not confirmed before DST was done. And that can be one reason the drugs now being used in the longer oral regimen, and teams are known to respond to those drugs. So that was just one perspective. To keep everybody's perspective wide, that because we live in India, it is not that we can forget non-tubercular mycobacteria. Of course, the presentation in the chest X-ray is also slightly different between TB and non-tubercular mycobacteria, but that, of course, can be a little difficult to use X-ray for telling us it's NTM or TB disease. But then the lab has to be sure what they're dealing with, because the treatment regimen, defining treatment regimen, the length of treatment regimen, everything depends on the species that we're dealing with. Thank you so much.
Thank you, ma'am. Are there any questions? No. Okay, Dr. Singla will.
So then you share my.
I think I agree with Dr. Shamim when he has raised this question of anabolic steroids, if possibly being used by we have seen anabolic steroids used by young men leading to even cardiac events. So this is something where immunosuppression could actually lead to dissemination and poor response to treatment. When the immune compromised status is there, delayed, like somebody did raise if there was a delay in response earlier, this can be one factor. So do we know about it? The history of intake of anabolic steroids?
No, ma'am. He's not taking any anabolic steroid, only is the protein intake.
प्रोटीन कैसे डॉक्टर साहब जिसको प्रोटीन बोला जाता है ना जिम में उसमें एनाबॉलिक स्टीरॉयड मिक्स्ड होता
And,
है
and that is a whey
तो
protein is
जी
whey
वे
protein is not
प्रोटीन
including
नहीं
his
आप जरा
anabolic.
वो वे प्रोटीन पिक करा लें और उसको किसी फार्मा में somebody who can actually look for steroids mixed with whey protein आप वो अगर करवा लें you will know the facts of what the whey protein is made of. There have been cardiac events. Young patients 20 years old have died because they were on anabolic steroids mixed with whey protein. So that just again to widen everybody's perspective.
Thank you, ma'am. Dr. Behra, I think, is still busy. So we go ahead with Dr. Singhla's comments.
Slide more to so you see in this case, just to brief again, this is a 31-year-old male who presented with weight loss and diagnosed as pre-XDR pulmonary TB and was put on BPALM regime with effect from 25th of February. And with repeated cultures being done, he was found to be positive. And even at the end of 5.5 months of treatment, we have a report culture positive. When you look at the genotypic reports, first and LPA and second and LPA, multiple times, 9th Feb, 4th April, 3rd of June, etc., this patient had INHN and CATG mutation present, and moxifloxacin was resistant and injectable were sensitive. Next. So the culture DST reports in the baseline, that is 19th of Feb, it showed sensitive to all the drugs, bedaquiline, linezolid, clofazimine, moxi, delamanid, ethionamide, and PAS. Then in the 28th of June, moxifloxacin in the culture DST was reported to be susceptible and parazinamide was said to be resistant. And the last DST report was, the sample was sent on 29th of July and the report was available on 14th of October. It showed susceptibility to linezolid, clofazimine and bedaquiline and resistance to moxifloxacin. And radiologically, as we have seen, patient did not improve and clinically the patient has remained stable, and now with the new regime, patient is showing signs of clinical improvement. Next. So first of all, as is being discussed from the beginning of this session, is a patient who is educated, who has taken the treatment, the drugs are from the program, why did he fail? So we must look at this, that why a patient on BPLM who has fulfilled all the eligibility criteria and who has ruled out the exclusion criteria, still patient failed. So of course we have to look for things like we have to recheck again whether the patient was compliant or not. Even you see, this was in the beginning. February was the time when this BPLM was being scaled up in the country. So whether there was a period in between when the regular drug supply was not there, we have to look into it. Then again, the radiological findings, in case there are again, these are the patients may not respond as much to patients who do not have cavities or less extensive disease. Then also, you see, there are some anti-TB drugs like just being discussed, steroids and other things, which patient may be taking and they have interaction with bedaquiline. All these drugs which have interaction with P450 enzyme inducers or suppressors, they have more interaction with bedaquiline, less with predominant. Of course, it is there with predominant also, but more with bedaquiline. So that also we have to explore whether he was on some of these medications or not. And of course, the issue of malabsorption, it remains, as we have discussed multiple times. So in this case, whenever you find a person with other things taken care of, as we discussed, and is not responding to treatment, it remains sputum positive, then TDM we should do to really see whether the drugs are reaching the blood or not. Next. Now coming to the patient has failed, patient is with us, we have to treat him. So when we are deciding the regime in such cases, like we take this example, the first choice should be patient, the drugs which patient has not taken, and we have a DST report from a lab which says it is sensitive. Like we have clofazimine, amikacin, and PAS, which is patient has not taken, and we have a report that they are sensitive. regarding past, you see, the patient was sensitive at the baseline also in the month of February, and after that, patient has not taken it, and this past report was at the baseline. But subsequently, patient has not received it, so we believe that it could still be effective. Second choice should be the patient has not taken the drugs, and the sensitivity report from the lab is not available. Like cycloserine, patient has never taken, but report is not there with us. Delamanid patient has not taken, but the report is not with us. So even these two drugs can be considered in such cases. Third choice is patient has taken the drugs, but still the current laboratory report says it is sensitive. Like in this case, patient has taken bedaquiline linezolid for more than 5-6 months. Still the lab is saying it is sensitive. So this we should take with a pinch of salt that not necessarily that patient is sensitive and these drugs will be effective. So they are always third choice, not first or second. Then fourth choice is the patient has taken the drugs, but the laboratory reports are not available, like predominant. So here also, because the this again should not be a priority in treating these cases, these drugs. Next. So when we combine all these four choices, the regime consists of clofazimine, amikacin, cycloserine, delamanid, PAS. These are the five drugs which come in the first or the second choice, and then the bedaquiline and or linezolid that can be added. Although patient has taken it for the 6-7 months, and lab is saying it is sensitive, but I do not feel that they will not be called so-called reliable drug to be treated in these cases, while the first five drugs are more likely to be reliable to be treated. And of course, once we start on this regime, it should also be guided by TDM also. To really see that patient has failed earlier, we are not sure whether even these drugs will be absorbed or not. So we must keep in mind that once we start this treatment, we follow the protocol of the TDM. They let him take it for 2-3 weeks, and then there is a protocol how to do the TDM. We need to follow that. Unfortunately, in our hospital, we are doing TDM to second-line drugs like bedaquiline, delamanid, linezolid, and fluoroquinolone. So that help can be taken in such cases. And another thing I would like to highlight is that by choosing these five drugs, clopa, mica, cyclo, delamanid, and PAS, we have five new drugs which patient has not taken earlier. So they are likely to be effective. Issue with PAS will be that availability. We are not sure whether it is available or not. In case we can manage that, that will be good. Bedaquiline and linezolid, as I already said, although the laboratory is saying sensitive because patient has taken it for good 6 months, and we are believing patient was compliant, the dosage was correct. So I really have doubt about their efficacy at this stage in this patient. And etunamide and pyrazinamide have already been declared as resistant in this case, so they will not have any role. So that's all I have to say in this case. The regime I've already shown what I would like to suggest in this case. And regarding bedaquiline linezolid, it is the choice of the treating team whether they want to include one or two of them. That is, but they must follow it again with the TDM also. And also, as we have been discussing from the beginning, before enrolling any patient in BPLM regime, please take care whether patient is eligible or not, whether there is any exclusion criteria or not. Look at the laboratory reports in detail, as has been done in this case also, and make a strict vigilance, ensure the drug supply is there, ensure that patient is compliant. In case of any adverse reaction, patient should immediately report to the system, and they should be taken care of. And regular follow-up clinically as well as radiologically and microbiologically, they are important in this case. Thank you.
So there's one more question in the chat box related to your talk only. Suppose if we do the TDM and the levels are low during the BPLM treatment, what shall we do? Should we increase the doses of the drugs and extend the duration, or shall we switch the patient to oral or longer regime during BPLM?
I think very good and very practical question. If somebody is on BPLM and you find you've done the TDM and you find the levels are low. You see, as of today, unfortunately, we do not have any guidance of increasing the dose of bedaquiline or delamanid or pretomanid. So in such cases, firstly, we can have a look why the levels are low, suppose why there is malabsorption. Sometimes, very rarely, we have found that when you take the gastric biopsy, they show tropical screw is there, celiac disease is there. So there we know that this is the cause of malabsorption, but that is a very rare phenomenon. So in these cases, once we find levels are low and we do not have the option or any recommendation for increasing the dose, we may have to shift to the all or longer regime.
We have Okay, we'll take comments from Dr. Mattu sir and Dr. Rishi sir. Mattu sir.
Thank you, madam, and thank you, Singla sir. Sir, Singla sir, as you suggested, we agree with your opinion. My point here is like when we are seeing this next available regimen is the longer oral regimen, which is there, and you have tried to go with again the principle of the management, which drugs were not used and the drugs used if they are sensitive or not. That principle you have used. My question is like still the bedaquiline and the linezolid, they are the strong bactericidal drugs, and they are sensitive also, though they the history of 6 month usage is there. Might there be some chances like the physiology which were not allowing these bedaquiline and the linezolid becoming effective, the management of this tuberculosis? Same physiology will not be allowing or failing us in this regimen also. And should we not consider this bedaquiline and linezolid to use in this regimen, next available regimen?
Yes, I think very good point you have raised, Dr. Mattu. You see, whenever we are making a regime, the basic principle is we have to choose 3, 4, or 5 drugs which are likely to be effective. When we say likely to be effective means best is patient has not taken them, and laboratory also says they are sensitive. Or the next best is patient has not taken them, but we do not have a laboratory report saying it is sensitive. So they are the drugs which are most likely to be effective. Now, after this, we have a situation where patient has taken regularly with good compliance, with good dosages for 6 good months and still has not responded. So that means now these drugs cannot be relied upon. We are cornered, we have limitation of the number of drugs. Yes, we will try to add them, but they should not be counted as a reliable drug of this regime. So as a layman, people also say that we like to give only 0.5 marks to these drugs and 1 mark to the other 5 drugs which I have said because they have not been used and they are sensitive. So that's how we make a regime. And whenever we are cornered, like practically I find even in this case, most of the drugs are bacteriostatic. Only Micacin is the saddle drug. So in this case, I won't mind adding 1 or 2 of the bedaquiline and linezolid drugs along with this. But otherwise, they are definitely, as a principle of treating a case, making a regime, they will be taken as less likely to be effective. Other 5 will be taken as more likely to be effective drugs.
Thank you, Dr. Singla. Dr. Rishi sir.
What about the chances of the physiological thing, like the new regimen, that if we, what may be the chances we may have the same fate in this? Yes.
But Dr. Mattu, which physiology are you talking about is not clear to me.
Like these drugs are sensitive, bedaquiline, linezolid, and this BPAL medicines regimen. Still, it was not workable regimen. So similarly, like we are trying these new drugs. So if they are also sensitive and same results might be there, because the internal physiology and internal dynamics of the person is not allowing them to be effective.
So that's why we discussed that even as I think Dr. Uruchi also mentioned, while patient was on treatment and was failing, we should have done the TDM also to know what is happening, whether the drugs are being absorbed, they are going to the blood in adequate concentration or not. And when I'm saying we make a new regime, even in this regime also, in case the facilities are there, we should check the blood levels, whether the person is able to achieve the blood levels or not. So that will be a ideal way of treating this patient. But whenever we start the empirical treatment, if we have good 4, 5 drugs which are there, we can start with this. But here we do not have so-called good drugs in terms of bactericidal drugs. Then we can choose these two, the bedaquiline or linezolid to start with as an empirical regime and measure the blood levels and then take a call what exactly is happening. Because you see, secondly, the sensitive specificity of the second drug is not 100%. When lab says sensitive does not mean it is sensitive only. It can be other way around also. So that also we have to keep in mind. Because 6 months is a long period. If somebody has taken the drugs in regular dosages, appropriate dosages, regularly, fully compliant, then chances of failing of this regime will not be high unless the drug is resistant. So that also we have to keep in mind.
Any role of surgery in such patient where there is a cavitary disease and not breast?
Yeah, you see, surgery is definitely not the first choice. First, we should treat with the chemotherapy, so-called the drugs only. In case patient becomes pathologically negative, clinically improves, radiologically improves, or remains same, it is okay. The surgical indication will only come when you find there are thick wall cavities and patient is not responding to your treatment. In those cases, we try to combine the resection surgery along with the ATT. Second indication is then you have treated what patient is left with multiple post-TB sequelae and is having repeated chest infections, is having repeated hemoptysis, so it's a post-TB bronchiectasis. That is another indication of thinking of surgery. But as a first side, we should choose a good regime, give the treatment to the patient, monitor him pathologically, clinically, and then see what is happening. Surgery is not the first option in such cases.
Dr. Rishi, your comments, please.
Yeah.
Dr. Mattu sir, are your queries answered?
Yeah, my points are clear. Thank you, sir. Dr. Vinay Garg is also with me, and he was suggesting, I don't know, Dr. Singla sir may give his opinion on this. He was suggesting like when the bacteria is not responding, somehow he was saying that this hyperbaric oxygen radicals may give some support in these cases. This was one of his question.
Yes, sir. That is one of random thoughts, sir. As
Yes.
it is in other types of fungi or other infections. Does
So we had, in fact, if I may, I'll just take a minute. So we had, when we had rolled out BPAL-M, we had clearly instructed that each of these patients are, given a TB champion to support. Our STS, our TBHVs make visits to their homes. So this was the direction we have been repeatedly giving. So whether such a thing was done in this case, if not, then we are repeatedly recommending so that we identify adverse effects early and switch the patient on alternate regimen when required. Also, if the patient is not gaining weight, if he needs nutrition support, the government is doing enough. Those linkages have to be developed where champions can help, and sometimes community volunteers also come forth. So these are the things we have been advocating, because what we are trying to move towards is personalized care. So we would appreciate if all the DTOs also come on board with this. There are TB champions available in all states, especially, and then what we've been actually trying to do is at least 2 champions in every village. So if that can also be facilitated, somebody to handhold, somebody to for Nikshay Mitra initiative also, if the patient gets adopted, we have been trying to focus on enabling our MDR TB patients get the Nikshay Mitra support first, also a TB champion, TB's health visitor, STS to carefully supervise these patients. So that will enable early detection of any adverse effects or change of regimen required. And of course, if the patient is taking adequate nutrition, taking his drugs regularly, all that matters quite a lot.
Thank you, ma'am. Thank you so much.
Circle.
Dr. Behra sir, he
was
was there, but I think he slept. Dr. Behra sir, are you there?
I am there from the beginning.
Sir, आपके comments रह गए हैं.
नहीं ठीक है. I think the my comments. I heard the first case also. I think both they were discussed very nicely, and the issues exactly that is what I wanted to tell. That is what Dr. Urvashi also told. Then Dr. Singla also clarified those points. And I think only one more thing I can just add. You remember, any treatment or any therapy is never 100% effective, because there may be some reason or other. So there will be a failure. Sometimes the reason we do not know why it happens. So always we should not expect that all 100% or all patients will be, will be 100% success. That is only one thing. Even if you are doing everything, it may not be possible, and we have to accept that. And then second patient, I have nothing specific to to add. He had some problem with the slides, but that is okay.
Thank you, sir. So, Dr. Rishi, any burning comment?
Yeah, yeah, ma'am. Thank you. I'm sorry for I apologize for the internet connection low. The thing, sir, which I have heard from this is that when my concern is that if a patient is having, say, DSTB treatment he have taken in his childhood days, and if he again comes with RR, so it has to be. Is this patient is comfortable with BPAL? My second question is that if a culture is positive, so and if two cultures are repeatedly positive, so at that time only we should have changed, have given the outcome as treatment failure. And my third question is that we are saying the whole genomic sequencing, and I think that whole genomic sequencing detects the DNA of the bacteria, so it might be live or dead. So culture is better than that, or whole genomic sequencing is better?
Whole genome.
That's it.
WGC.
No.
I think Dr. Urbasi very clearly told that phenotypic is the best. Anyway, I think let Dr. Singla comment on that.
So I would, sir, repeat, phenotypic DST is the gold standard. The genotypic DST can come in handy if we are trying to save time. So, but the gold standard is the phenotypic DST. Probably Dr. Anil mumbled WGS. That is incorrect because there can be mutations which are not responsible for resistance, which will be picked up in whole genome sequencing. We only want a mutation that expresses as resistance in vivo. So it is phenotypic DST always, but because of the time loss, we want to utilize the current technology, that is either targeted NGS or whole genome sequencing, to help us. For BPAL-M, I would like to repeat because there was a question in the chat box which asked, how can you give BPAL-M if there was MOXIE resistance high and low? So let me repeat, when we designed this regimen, a lot of literature search we did, and there are at least 8 to 10 scientific points in favor of adding moxifloxacin. And I would just summarize by saying the experience of TB practical trial clearly showed adding moxi even to those who are resistant to fluoroquinolones, we get recurrence-free cure. How it works is possibly the 4 drugs work in synergism, and this again is a proven, scientifically proven fact that when combining, synergistic action can bring down the MIC of different drugs. So that is how it works, and that is the India regimen, the BPAL-M. So DST is not required at the inclusion. The other criteria are very, very important to decide whether we are giving BPAL-M or we'd rather choose the longer oral regimen. But we are also trying to suggest, since the success rate of BPAL-M is 90% plus, if followed in the way the guidelines state, again, very painstakingly put together by our team here, have actually detailed everything, and we have experts, national level experts who guided the guidelines, and it was done very carefully, scientific evidence based. So please follow the guidelines and only put patients on BPAL-M when they are okay, according to the inclusion scheme. Thank you. I missed the first 2 questions, so in case I can address Dr. Singla, please tell me.
Thank you, ma'am. Thank you. So, are there any? Dr. Rishi, your questions are answered, I suppose?
Yeah, ma'am. Yeah, ma'am.
Yeah,
okay,
thank you. So with this, we come to the end of the clinic, and I think today was a very, very fruitful discussion where we not only revised the guidelines, but we were very lucky to hear all the people who are involved in making these guidelines. We have DDG ma'am, we have Mattu sir, we have Dr. Singla and Dr. Behra sir. We have all the senior people here who have really, made these guidelines. So I would say the take-home message for us, for the DTOs who are working in the field, would be that while we are starting the treatment, please take care of inclusion and exclusion criteria. The NTM, if it has to be ruled out, if any good lab is doing it, they will rule out NTM for you. And of course, a sample is always sent for the DST. When the patient is RIF resistance, the IRL will put the detailed DST for this patient. And when you are starting the patient, please do the follow-up see for the doses that patient is taking proper doses, kindly do the monitoring. And if there is no response to treatment, or if the patient is not responding on your follow-up cultures, please refer the patient to nodal DRTB center at the earliest. Please look in for any TB champions and any CHVs, the community health volunteers, if there is any problem with the adherence, and also do link the patients for DBT and for the food basket through a Nikshay Mitra. And while the patient is sent to the nodal DRTB center, they will look for the malabsorption, or if there is any drug-drug interaction, or the other things that we just discussed in the clinic. So I think as DTOs, we have to look into this and see for a regular follow-up of the patient. So with this, we end the clinic, and I request Dr. Ashok Bharadwaj, sir, who is the chairperson for NTF, to give his vote of thanks.
Thank you, Nita. Am I audible?
Yes, sir, you are.
Yes, sir. So thank you. And first of all, I must congratulate Dr. Anil Yadav, DTO Ghaziabad, for his presentation. I hope he has support from the adjoining medical colleges for managing the case of DRTB. So my only concern is the training part in BPL, BPLM regimen. So still if I say that we had 4 zonal workshops and about 16 states, when they did presentation on the training status on BPLM, it was just notional. So, but if we have to succeed in this regimen, we have to train all concerned, all experts down to the DTOs and to the CHO level. If we have to have success in upscaling BPLM regimen in country. So there were questions that also answered in the chat box. That is due to the lack of training part. So if quality training is done, then no such question will arise. So we have to do this wholeheartedly, and I promise that we will do it. So then today we reached 282 participants. So it's a bit less. It is not very satisfactory. So we should try hard. So thank you very much. Thank you, Rupak, for your comments. Thank you, Dr. Behra. Thank you, Madam DDG, Madam Dr. Rushi, for her excellent comments, because she is a master in this. So thank you very much. Thank you all.
Thank you, sir. So with this, we close our clinic. Please give your feedback. It has been shared with you. Thank you so much.